Why do we study pH? Essentially because it is responsible for disability, it's responsible for hemodynamic consequences of right heart failure, and of course for prognostic importance and important management decisions. And today, as we step into structural heart disease, as I asked earlier as well, we do a lot of TAVR, we do a lot of MitraClips. So we are stepping into different territories, much more than congenital and rheumatic that we've been used to. Just to recapitulate, this is a normal right heart hemodynamics. The normal PAP is considered anything more than 25 millimeters of mercury at rest. And of course, we have the RAP and the PVR. So overall, if we had to put it, this is again a thing asked in exams often for the DNP candidates. What is PAH? If it's PVR of more than 3 Wood units and a wedge pressure of more than or equal to 15 millimeters of mercury. We have to categorize pH. pH overall is categorized as either a precapillary pH or a postcapillary, depending upon which is the one that is causing it. Is it is it the LV leading to it, that is a postcapillary leading to it, where you will have a high LV EDP, or as reactive and passive. So the initial part of pH is usually the passive pH, and then the active pH gets into it once the obliterative changes in the lungs start to happen. Overall, if you see, this is the entire paradigm of how to approach pH in terms of echocardiography, where we have the echo findings right up there. So that's where sort of echo takes up. It takes center stage in how to decide for a pH patient. And of course, if it is low or if it is high, intermediate to high. So, and then of course, with now the EF, that is reduced EF, and the improved EF coming, there is much more to pH than just meets the eye. So as I said, to diagnose and to define pH, we need echocardiography to determine the etiology of it, whether it's left heart primarily causing it, to quantitate, or if it is congenital heart disease causing it, then to quantitate the PA pressures, of course, to evaluate the end effects and to determine the prognosis. Eyeballing is something that was already mentioned earlier in one of the earlier lectures. Eyeballing is not sensitive, but it is done generally by most of us. We tend to look for RA-RV dilatation. A teaching point here is that even if the RV is the same size as the LV, it's called dilated. It doesn't have to actually exceed the LV. Abnormal shapes of LV is causing a D shape so that it sort of bows into the RV and decreases RV compliance. RA dilatation, dilated PA, all of these can be just eyeballed and you sort of make an assessment that pH is there or not. And of course, abnormal pulmonary valve motion, which I'll come to. This is what it has come to almost. We always used to think that the holy grail is invasive. Yes, it is. But I think with the efforts of a lot of echocardiographers, one can say that echocardiography has taken over the invasive measurement. Unless we need to do it, we don't do it these days. We have the normal PA pressures. Echo has come up. So the question that we ask now is, how accurate is echo for diagnosis of PAH? Can simple visual assessment be enough? Yes, it gives us an idea, but then we still need measurements. If you see echo Doppler in terms of the right heart cath, we see that there's a good amount of correlation between the two. So we can definitely use echo. It is, and it is less invasive, of course, and you can use it at bedside, in sick patients, in ICUs, etc. TR jet, if you see in terms of feasibility with contrast and without contrast, TR and PR jet, since my talk was, PAH with and without TR, so TR and PR, if there's no contrast, you have a little bit of trade-off, but then it improves significantly when you put contrast along with TR and PR jets. PA systolic measurement, which it's used in multiple views, we have to take in multiple views again, and if we do that again, the sensitivity and the specificity of diagnosing PA systolic pressure being more than 50 improves significantly. So you take more than one view, we have to be patient about it and take about 5 to 6 views and then average it out, but then it has been found out that it is significantly better to do this and to get an accurate value. As I said, eyeballing, it can be seen that RA-RV dilatation, you can just make an assessment that if the RA-RV, as you see on the extreme left here, PA is dilated, the RV is dilated as compared to the LV, we can just eyeball and say, but of course this is not very sensitive. Echo signs, which have been told from the British Society of Echocardiography. If you see in terms of the ventricles, they are actually categorized as the ventricle, the pulmonary artery, and the IVC diameter. If you see an RV to LV basal diameter of more than 1, or if there is a flattening, that is what we call as an eccentricity index of more than 1.1 in systole and diastole. It has to be both in systole and diastole. It is sensitive for PAH. In terms of the PA pressure, I'll come to each of them individually. When you see a PAT, which is generally considered, if you want to measure it as PASP of PAT, half of PAT, that is 90 minus half of this value. If it comes to less than 105, And if it is worsening, if it is less than 60, it is severe PAH. PA diameter of more than 25, which is measured between the pulmonary valve and the bifurcation. I just come to each one of them. IVC diameter of more than 21. And as was mentioned by Dr. Shekhar as well, the sniff test is quite sensitive. You don't want to make them take a deep breath. You want a quick inward sniff. In that, if it collapses more than 50%, it's considered like normal. If it is not, then again, it suggests PAH. So in terms of pulmonary flow velocity curves, and this is an interesting point here. If we see in terms of just you put a pulmonary valve, a pulse wave Doppler across the pulmonary artery, and you see the kind of pattern that it gives you. If it gives you a nice dome-like velocity, like without any notching, this is more or less normal. It's not severe PH. But as it goes towards a notch, you have to go A, C, and then B. So if it goes towards a notch, it starts to notch, it tends to tell you that there is PH happening. And when there is a mid-systolic notch, it correlates with severe PAH. You don't need a jet for this. You only have to put a pulse wave across pulmonary artery, and it gives you this. So this is no notch, this is a mid-systolic notch, and this is a late systolic notch. So in terms of your way to signalize it, so this is the green signal, this is yellow, and this starts to get red. So this is a red flag. So when you start getting mid-systolic notch, it's important to see that if you see in terms of no notch, this is generally the left heart disease causing it. It's not primarily precapillary PAH. Absence of significant pulmonary vascular disease. As it tends to get PH, you start getting a late systolic notch. And then, you have got, it sort of correlates with moderate pulmonary vascular disease. But when it starts getting mid-systolic, all this has been actually, sort of correlated with the amount of PVR. If you see in terms of PVR, I just go back one slide again. So this is no notch, late systolic, and then mid-systolic. If you see in terms of the PVR, clearly if there is no notch, mid-systolic, and then late systolic. If you have mid-systolic notching, it's the highest of the PVRs among the three groups. An easy way of knowing pH only by a pulse wave Doppler.
Can I just interrupt you 1 minute?
Yes, sir. Yes.
It's called the flying W. When you're doing an echo and you do an M mode, you'll see this is called a flying W. So the other thing is that it can also be seen when the pulmonary artery is dilated. Pulmonary artery dilatation without pulmonary hypertension may also look there. So keep in mind that thing.
It's supposed to be an early sign, sir.
Yeah.
Right, sir. Right. So all this has been correlated between PA size of 20 to 25, as sir said. So you don't really need to have PA dilatation for this. Again, the same point. And when they've seen in terms of TAPSE also, you can see that the late systolic notch and the mid-systolic notch, the TAPSE decreases significantly with that, as compared to no notching. So obviously the RV function, it's an early indicator of RV dysfunction setting in, even before the PA starts to dilate. They have actually correlated this. It's an older study, about 10-year-old, but they have correlated that as the PVR increases, the shape of the notch will change. No notch to like late systolic to the mid-systolic notching. All the parameters start to get worse as the notching gets into the mid-systolic range. Another thing that is asked, like in exams for us, is that if you just eyeball an echo, how would you know it is PAH or PVH? So PAH versus PVH. So pulmonary venous hypertension would be much more likely if there is a left-sided heart disease. So the LA starts to enlarge. The atrial septum goes towards the RA. You have an E by E ratio of more than 1.2, E by E lateral prime of more than 11, and a lateral E prime of less than 8. RVOT notching is quite uncommon. As I said, this is the first group of the three, the extreme left, which I showed you earlier. As compared to this, PAH would be much more likely if the RV is dilated. The RV is much more. The LA size is relatively okay. It's not really so bad. The atrial septum now starts going towards the left side, towards the LA side. The E by A ratio is less than 1 still. RVOT notching starts to come. So this is much more likely to portend towards a PAH rather than a PVH. The other visual estimates, you can actually measure the PA diameter. So you have to correct me if anything is wrong in this. But then it's not done these days. But then if you see it right in the center, somewhere between the valve and the bifurcation, right in the center, if you see, it's more than 25 millimeters considered as abnormal. M mode, if we see in terms of the pulmonary valve, if we actually put an M mode there, so you have a classic EF ABCD pattern in which the EF slope starts to reduce, the A dip starts to come down, and of course the notch starts. That is your flying W, which sir was saying. So all these three will portend towards a PAH. This is again a visual estimate. Sure.
Can you go back to that
Sure, sir.
previous slide? So the A dip, we used to call the A dip, become actually smaller when there's pulmonary hypertension.
Yes, sir.
But then again, when the patient with pulmonary hypertension develops right heart failure, so then the pressure again, the
Rises
pressure
up.
right will
Yes.
go up, and then the A dip actually becomes
Bigger notch.
louder.
Bigger
So,
notch, sir.
so the A dip will become smaller with pulmonary hypertension, but then with right heart failure, again, it becomes even larger than it was before. And of course, you have this rapid opening slope. Yeah.
Yes, sir. The EF slope.
That was the very first project I had on mode echo, which I did when we found the pulmonic valve. This is what we decided about how to make the diagnosis of pulmonary hypertension using the A dip and the pulmonary artery slope. Yeah. So that was I think I was a teenager at that time, 1972 or something like that.
This must be from one of your studies only, sir.
Yeah.
So this is essentially, you have the flying W here. You see that the slopes the BC slope is rapid, the A has gone down, and the EF slope is almost not there. And the systolic notching has to, like I started already. Eccentricity index, what I actually mentioned earlier, it's actually the D1 and the D2 are the two diameters which are taken. And then when you see in terms of the eccentricity index, which has been mentioned, the D sign, that is D2 by D1 is the eccentricity index. So if you see in terms of normal, the eccentricity index should be less than 1. But as the RV starts to bore towards, the septum starts to bore towards the other side. Oh, sorry. It's going the other way around. So it starts to go towards the other side. You tend to start getting an eccentricity index of more than 1. So you have a pressure overload here. So the EI starts to go more than 1. So that's the D2 by the D1. So and if it is not so, if it is volume overload, it would be like less than 1 again. So PAH, you'll have this kind of a pattern where there's a EI of more than 1. Again, one of the features, sort of a corollary feature would be a dilated coronary sinus, which can tell you that there's an increased RA pressure, something that we see very commonly in ASDs, for example. CAS is dilated, of course. As I already mentioned, RV, LV, basal diameter ratio, these are all actually eyeball ratios. You don't need any PRTR for this. So if you see in terms of a ratio, of basal diameter of more than 1 is considered abnormal. So even if the RV is the same size as the LV, it's considered dilated. RA area also, actually been used to estimate the PAH. The RA area is considered more than 18 centimeters square as abnormal. You can see, this is one of the patients that we had with the PAH, with the MS and TR. So the RA is like really, really large. It's more than 67, but anything more than 18, in some books says 20, is considered 20 centimeters square is considered abnormal. RA strain is an evolving subject, of course. I couldn't get much of data on that, but there are a lot of snippets mentioning that RA strain is also being used nowadays to estimate pH. Of course, other corollaries would be if you see an evidence of pericardial effusion, RV failure, of course, that is again an indication that there is a PAH happening in the patient. And of course, the RV diameters. Now, this is something interesting. The RV diameters have to be mentioned at 2 level. You can actually measure it. The RV D2 is measured at the level of the LV papillary muscles, and the RV D3 is measured from the annulus up to the tip. So, an easy way to know it is at the basal, if it is more than 41, and you can just remember 41 into 2, 82 or 83. This 41 here and 83 here are actually the upper limits for what can be considered as normal. And RVD2 is measured at the level of the LV papillary muscle, if we can do that. We can also use the pulse wave velocity, the fraction area change of the RV in the RV focused view, and of course the Doppler S velocity, which is considered as like less than 9.5 is considered to be an abnormal RV dysfunction with PAH, and E by E prime of less than 8, as was already mentioned earlier. You can say the FAC here, so the area diastole upon the area systole upon the area diastole, if you see in terms of 100. So if it is here in this slide, it is more than 30% here, FAC.
Again, this is always the problem with echocardiography dropouts. If you see the tracing on the left one in the A, how good is the tracing? It's not going, there's no real continuity there.
It should have
so
come inside.
many times when we do this,
right.
we have a lot of these dropouts.
Right, sir.
So many times these linear dimensions are better sometimes than these trace dimensions. See, that's not reliable at all.
Yes,
Maybe a little bit better on the B, but the A is not very reliable. So keep in mind, how it is done also, because all these intra-observer variability will be very high when you do this, right?
Right, sir. Right. We can also use pulse wave Doppler from the hepatic vein and E by E prime, as was mentioned earlier, of less than 8 is considered as abnormal. Here it is E by E prime of E by A of 6.7. So all these modalities can be used also as corollaries for PAH. In the observational methods, the issue is that you can have it as a systolic flattening of the IVS. We can have coronary sinus dilatation. We can always infer from that what is happening. So if we have this eccentricity index, which is more than 1, RV pressure overload is taking center stage. CH dilatation, elevated RA pressure is what we are trying to make out here. IVC, again, the same thing, pericardial effusion and TR. So the inference can be made out summarily with all of these. If we have TR and PR jets present, our life becomes much easier. We can use all of these methods, which is the TR velocity jet method, which I was alluding to earlier. We should take the chin and not the beard. The PAT method, the PR method, and the RV isovolumetric relaxation time method. So TR jet has been amply, done and practiced by all of us. So essentially, we look at the TR velocity. If it is less than 2.8 to 3.4, or more than 3.4, in terms of whether it is low, intermediate, or severe. So we go with the Bernoulli equation here, essentially the 4V square. So the peak TR velocity is normally less than 2.8, even as per the AAC guidelines. And if we see in terms of what we essentially do, we look at the RA pressure, which I've written as JVP here, and of course, and the delta P. Delta P would be the 4V square. So if we see in terms of what we are measuring, we are seeing a TR jet here. We have to have our adequate Nyquist limit as Sir said of more than 60, which we have mentioned here is 62. And then we see in terms of what is the velocity. We need to get a complete jet. Amputated jets can make the diagnosis really wrong. And as Sir said, we have to go for the chin, not for the beard here. So we have to just come to that. So we have a complete jet here. So we have to take it somewhere here, not exactly the beard, right down, and we can get a better idea of what is the PA pressure.
Asterisk which you put in there is at the wrong place.
No, it is not at the right place.
Yeah, not in the right place, because that's more near the beard than the chin.
Other than the chin. Yes. So this has gone to the beard. This would be better, I guess. Sir. So the peak TI velocity here, 4V square. But the question is that all? No, we have to add the RA pressure to it, as was also alluded earlier by Dr. Shekhar. We have to add the RA pressure, of which we go with the IVC diameter, in which the absolute value, and of course the diameter, which has been revised, as you said. And then this has also been seen in terms of the intra-cath gradient. It sort of correlates really well. Simultaneous cath and Doppler, it has shown that it is a very good measure to do it. IVC collapsibility index, what was mentioned. So less than 1.7 and 50%. This is an older slide. This is the earlier slide which was actually mentioned. Now it is this what he had again alluded to. This has all been done in the earlier talk. I'm just going a little faster. So if it's now considered less than 2.1 is normal and more than 50% with a sniff. So if it's more than 2.1, but if it still collapses less than 50%, it's 5 to 10. As I said, we take an 8 here because it's neither 3 nor 12. So it's considered around 8 now. So it's more than 2.1, and if it collapses more than 50%, it's still good. And if it is RA pressure, if it is more than 2.1, it is abnormal. And if it collapses less than 50%, it shows a really high RA pressure of more than 15 millimeters. Again, there is no data to go above 15. So that of course is one of the drawbacks of this method. Again, coming to the same point. As Sir had already mentioned, I can skip this because Sir has already discussed this. We have to mention 1 to 1.5. 1.5 is what is generally considered. 1 to 2 is considered. We have to take into the IVC from the outflow of the IVC. So this is definitely dilated there. And expiration and inspiration, you have minimum amount of collapse. Sorry, I have to go a little faster. Respirophasic views can be taken to see exactly the exact collapse happening in the inspiration and expiration. And if it is or it is not collapsing. Of course, I said limitations is the patient needs to cooperate. Tachypneic patients, mechanical ventilation, we cannot do that. Secondary indices, I'll just skip this for time being. As I said, as Sir is also I also mentioned, amputated TRJ should not be used, and we should use the chin rather than the beard. Just come to the other methods. PR jet has been used. PR jet essentially is when you take a PR jet and then you get a trace, and then you look for the PA EDP and the PA mean. The PA mean would be here, and the PA EDP would be here. And it's something that we use very commonly in congenital heart disease also. The PA mean would be up here, and the PA EDP would be down here. And then you add the RE pressure, of course, to that. I'm sorry, I have to go a little fast. PAT can be used. PAT is taken when you put a pulse wave across the PA and then you measure it as a RVOT signal, typical RVOT signal, in which 90 minus half of PAT is considered as, this is how you actually calculate it. So in severe hypertension, it goes less than 60. There are actually various like formulae, 80 minus half of PAT or 90 minus half of PAT. Some people add 0.6 PACT. RV free wall strain can be taken. Free wall strain of less than like minus 15.5 is considered as abnormal. Here we had some patients with less than minus 14 in severe pH, relatively okay, minus 18 in moderate pH, and was normal in other patients. IVRT has been taken. IVRT of more than 70 milliseconds, 75 milliseconds is considered normal, and less than 40 has it's considered PAH, and less than 40 has got a significant negative predictive value for PAH at all. So less than 40 is 97% are negative, and more than 75, 94% are positive actually for PAH. TI index has been used. I'm sorry, it's a very long topic. I couldn't finish it. PVR has been taken by the Abbasi formula. This is a formula that's very commonly asked in exams, where you take the peak TR velocity by the VTI, RVOT, and you multiply it by 10 and you add 0.16. It's called as the Abbasi formula, and it has been shown to correlate well with the intracardiac as well. I'll skip this because here are all the prognostic factors for PAH. TAPSE has been seen, PH in left side disease. One thing I just wanted to mention is about PD flow in preemies. We get a lot of these in our hospital, CSI hospital. So we have these patients who come, who are really small, and PDA jets can actually sometimes, give you a wrong idea, because as was mentioned earlier, pH, the PR comes exactly there. So you may get a bit of contamination there, and generally invasive is found to be better than that. So putting in a nutshell, pH is independently, it sort of carries an unfavorable prognosis, whether it's severe or moderate. And historically, we have been always measuring it invasively. Echo is great, and especially with features like TDS and now the GLS that's coming in, it's made great strides. And non-invasive and invasive have been found to have quite acceptable reliability today. Thank you so much.